Channel. Now we are in pharmacokinetics distribution second part, that is we have already completed absorption. Now we are in distribution. So what is distribution? As a name only you can understand, it is nothing but distributing into tissues or different organs in our body. So any drug which we given by intravenously or by oral, anything, it gets distributed in the body for in plasma concentration or blood concentration. First it enters and next from that it distributes all over the body. So that is what nothing but distribution. So it now we can understand that it is mainly dependent on lipid solubility, because every cell is having bilipid plasma membrane layer outer every organ, every cell. So it need to cross the membrane, then only it can get distributed. So it is mainly dependent on lipid solubility and also even on ionization. As we said, if the lipid is unionized, then only it can easily enter. If ionized, then it is not enter. And also on pH, pKa. So all this we need to remember. And we are having for this formula like thing, that is apparent volume distribution, that is mainly determined by the dose administered mainly by IV route by plasma concentration, that is how much we have given and how much it is present in our plasma concentration. So if we divide this together, we get the apparent volume distribution. So V is nothing but the volume which can accommodate drug in the body, so if the concentration is same as in the plasma. So this is what I have been checking the diagram to understand this. So the total amount of drug in the body, for example, is 1000 milligrams, and we have given an IV injection that is entering into the blood. So the plasma drug concentration is about only 50 milligrams. That is, as we given the drug now in the blood, there is about 50 milligrams. And how much is in the body? So to understand this, we use the formula V is equal to 1000 by 50. That is 1000 total amount of drug we are given by IV, and 50 is the how much drug is present in our plasma at present. So 1000 by 50 we give 20 liters. So what is this? So illustration of the concept of apparent volume distribution in this example produces a steady state plasma of 50 and the apparent volume of distribution is 20. So now we can say that the 20 liter of the drug is distributed into the body. Actually this is inappropriate, like how can we say 20 liter it is in our body, but it's like gives a value that how much amount of distribution is going to take place in our body. So here the lipid insoluble drugs can't enter the cells. Yes. So what are the examples of this lipid insoluble? That is streptomycin, gentamicin of 0.2 liter per kg. So the streptomycin, gentamicin are, as they are lipid insoluble, they just stay there, but they can't enter the circulation. So we actually try to give them in different ways, not by as these are not distribution, we give it in different ways, like in oral ways or in rectal ways or sublingual, etc. So the drugs which are actually binding to the plasma proteins are restricted. So if you can understand this concept, like for example, if we bind some drug to one protein, it is binded there with so much affinity that it is not now interested to come to the circulation. So it is just bounded there and remain there. So these are like restricted drugs, because as they are bound together very strongly, now they are not wanted to flow in the body, so they are restrictions. So these kind of drugs are like example, we have the phenylbutanazole and warfarin. Actually warfarin is having 99% it is bound, so that it can't move. So it is only having a volume of distribution of only 0.1 liter per kilogram, that is very low distribution in our body. Next, the drugs which are having the high value of this V are like in digoxin, you can see that it is about 6 liters, it is highly distributed, and propranolol it is 4 liters, and morphine 3.5 liters. So here the drug is more in the tissue, so the plasma concentration is low, right? So now you have observed that the drug is now distributed a lot in the body, means in the plasma there is only some, because now the drug is more in our body. And in the large volume distributed drugs, that is sometimes poisoning. We know whenever we take any drug in a higher concentration, it may cause poisoning. And remember that the drugs which are having high volume of distribution, that is, they are highly distributed in our body, and if such drugs are having poisoning, it is very hard to handle, because it is not removed by the hemodialysis system also. So this is very dangerous in case of poisoning. Where the drug is highly distributed in our body. So in some pathological conditions like congestive heart failure, uremia, cirrhosis of our liver, what happens is actually our body normal physiological method is altered now, that is the membranes are altered, its functions are altered. So as all these are altered, the drugs are also altered, like where to bind and what to do. So the drugs mechanism also get altered because of these kinds of diseases, and their binding sites are also altered. So once let us check out that the factors governing the volume of drug distribution. You can see, for example, lipid, the water partition coefficient of the drug, and pK is the value of the drug. So these are all the factors which is mainly dependent on drug distribution. And degree of plasma protein binding, affinity for different tissues, fat or lean body mass ratio, and diseases like chronic heart failure, uremia, cirrhosis. So all these are mainly dependent. Now let us understand the concept of redistribution. Redistribution, in the name only you can understand, that is, first it is distributed to tissues, and again it this reaction is irreversible. Again they unbound with that specific protein or tissue, and again they come and distribute to the different organ again. This is nothing but redistribution. And remember that the drugs which are very highly lipid soluble are easily redistributed, because very high lipid soluble means first they will go to one other tissue of the body and again move to the other tissue. That is nothing but redistribution. But remember, the drug which has undergoes the redistribution, they finally terminate the drug action. That is, they may excrete or they finally stop the drug action, because as they are redistributed like many times. So for example, these are the drugs which are taken by intravenous route or inhalation drugs. They are distributed to the blood flow where there is high blood flow to the organs, example like brain, heart, kidney. Here there is very high blood flow, so first they reach to the organs. And remember that this decrease in vascular flow, then increase in bulky tissue, like in this also there is redistribution taking place, like in muscles, fat, which take the drug, decrease the plasma concentration, undergo the redistribution, and finally termination of the drug action. So same drug repeated or continuous and decrease perfusion, high capacity sites get filled and the drug is longer acting. So as this is redistribution, in the name only you can understand, as the drug is now having higher capacity to get distributed morely, and now the drug is also having the longer activity in this case. Next, coming to penetration to the brain and CSF. So we know in our brain we are having blood-brain barrier. So it is mainly made up of endothelial cells, very tight junctions, and also neuronal tissue covering this capillary layer. And we are also having blood CSF barrier for the CSF, which is mainly present in our choroidal plexus. So both these are not allowing any lipid insoluble drugs. Soluble drugs, lipid soluble drugs can allow, but lipid insoluble drugs are not allowed in this case. So example here again, streptomycin, neostigmine, hexamyocin, dopamine. But dopamine, when it is converted into levodopa, it can enter, and it is mainly used in a Parkinsonism disease. So remember that in penetration to brain and CSF, only lipid soluble drugs can penetrate. And for example, in inflammation of meninges, there is high amount of permeability for the drugs. And enzymatic blood-brain barrier is also present, that is having monoamine oxidases, cholinesterases, along with enzymes in the capillary wall and cells lining around them. So this enzymatic blood-brain barrier don't allow catecholamines, serotonin, acetylcholine, and also which are mainly present in the active form. So this active form compounds like catecholamine, serotonin, acetylcholine, all these are not allowed in case of enzymatic blood-brain barrier. And the blood-brain barrier is deficient at CTZ level, that is at the medulla oblongata, periventricular sites, and also anterior hypothalamus. So in these areas, even the lipid insoluble drugs can also enter here. And but remember that in the blood-brain barrier, the outflow is not restricted, that is lipid soluble drugs, lipid insoluble drugs, all can get out from the blood-brain barrier. It is unrestricted, but only the inflow is restricted only for the lipid soluble drugs. And next, coming to the non-specific organic ion transport, which is mainly present in a choroid plexus, and there is bulk flow of CSF going on, and drug here by the drug movement here can be done by the arachnoid villi, and all can pass by the placenta. So we know placenta is not acting like a barrier here. Even the lipid soluble, lipid insoluble drugs can enter. Remember that mainly lipid insoluble drugs can enter only if the drug concentration is present for a very long time in a mother, so that from mother it can easily enter into the fetus. And next, coming to the acidic drugs. So here you can see the acidic drugs are mainly binding to the albumin, and the basic drugs mainly bind to the alpha-1 acid glycoprotein. So once we'll check out this diagram, that is the passage of drug across the capillaries, how it takes place. So A is the usual capillary with large intercellular pores. You can find out that through which through which even large lipid insoluble molecules can also diffuse. And here B is a type that capillary constituting blood-brain CSF barrier. Tight junctions are present between capillary endothelial cells, and investment of glial process or choroidal epithelium do not allow the passage of non-lipid molecules in case of here, that is blood-brain barrier around CSF, all this. So this is a usual capillary. Intercellular pores, lipid insoluble drug can also enter. Lipid soluble non-polar drug can also come out and enter endothelial cells, usual. But coming to this is special type, only lipid soluble can enter, but lipid insoluble can't enter, and the glial cells and process on this brain capillary. So let us continue our theory part. So we are having acidic drugs which are having small charge can alter the protein binding, like sulfametazine 30%, sulfamethoxazole 60%, sulfadiazine 50%, sulfasoxazole 90%. And basic drugs are bound to alpha-1 acidic glycoprotein. We have discussed this already. So if there is more amount of drug concentration, it may saturate the binding sites, and increase in bounding of the drug decreases the volume of distribution, as I discussed before. So the binding is temporary for the storage of drug, and increase in protein binding is creating a drug for the longer acting, because it is protein bound for a long time in the blood, in our circulation or in our plasma concentration, so that it gets released anytime when needed. And increased protein binding, bound drug have less amount of metabolism and excretion. Remember, the drug which is bound to the protein can neither go to metabolism or neither go to excretion. And next, active tubular secretion decreases the concentration of the drug and increase the renal clearance. That is, there is more amount of chances of excretion of drug mainly by active tubular secretion. And in excretion of penicillin, metabolism of lidocaine, which are mainly bound proteins, they act as carriers. And two or more drugs can bind proteins, and sometimes higher affinity one can displace, or sometimes both remains. Example, here we have probenectic and inclomethacin, which are bound to albumin and they don't displace each other. And next, acidic drugs are generally don't displace basic drugs and vice versa. So important displacement interactions we'll discuss. So before going there, let us check out the drugs which are bound to the plasma proteins, that is to albumin and alpha-1 acid glycoprotein. To albumin, there are all like B for me, barbiturates, benzodiazepines, NSAIDs, valproic acid, phenytoin, penicillin, sulfonamides, tetracyclines, tolubutamide, and warfarin. These are we need to remember, so we need to get them clear. We need to remember, revise them many times. Alpha-1 acid glycoproteins, we're having beta blockers, bupivacaine, lidocaine, disopyramide, imipramine, methadone, prazosin, quinidine, and verapamil. So these are the examples which we need to remember. And yeah, we have come to last. Next we'll continue biotransformation. So before that, finally we are having our where we are. So important interactions are like phenylbutazone with salicylates displacing tolubutamide, and indomethacin ethanoic acid phenylbutazone displacing warfarin, and sulfonamides vitamin K displace bilirubin, that is keratonicus in neonates. Salicylates displace methotrexate. In hypoalbuminemia, there is decreased amount of binding and increased amount of free drug concentration. So example, you can take phenytoin and furosemide. And example is phenylbutazone, digitoxin, phenytoin, pentacillin binding reduce in uremia, and propanol binding increase in pregnant female, and patients with inflammatory disease have acute phase reactant alpha-1 acid glycoprotein is increased in them. Next, coming to tissue storage. So tissue storage mainly in skeletal muscle, heart is mainly digoxin, hematine, Thomas de proteins, and liver we have chloroquine, mepacrine, tetracycline, hematine, digoxin, kidney digoxin, chloroquine, hematine, thyroid iodine, brain chlorampacazole, acetazolamide, and isoniazid, and in retina chloroquine and nucleoproteins, in iris epinephrine, atopic, to melanin, bone and teeth, tetracycline, heavy metals, to mucopolysaccharides of connective tissue. So adipose tissue, thiopentone, ether, minocycline, phenoxybenzamine, DDT dissolve in a neutral fat due to increased lipid solubility and remain stored due to the poor blood supply of fat. Actually, sometimes they also exert some local toxicity in the drugs. That is, example, tetracyclines on bone and teeth, they form toxicity, and chloroquine forms toxicity on retina, emmentine on heart and skeletal muscle. And drugs may also selectively bind to specific intracellular organs like tetracycline to mitochondria, chloroquine to nucleus. So till this we completed distribution. Next we will continue with final metabolism and excretion.